Thank you very much to the organizers for the invitation to be here today. I'm asked to talk about double-hit lymphoma and the standard of care. So I promise that I will keep us on time because I am giving a talk on a topic where there is very little data, and therefore I can't be wrong or right, so thank you for that. I have no disclosures. So what is double-hit or triple-hit lymphoma, for that matter? This is an entity that has changed names frequently over the last 10 years. Now, the latest WHO classification from 2017, the official name is high-grade B-cell lymphoma with MYC and BCL2 and or BCL6 rearrangements. We call it double hit or triple hit because, of course, that is much easier to say. This was previously known as B-cell lymphoma, unclassifiable, with features intermediate between DLBCL and Burkitt lymphoma. And prior to that, it was sometimes just called high-grade lymphoma or Burkitt-like lymphoma. Why is this important? We know that these patients have a much worse prognosis than those with other aggressive B-cell lymphomas, such as diffuse large B-cell lymphoma. So I'd like to give us a case to put this into context. This is a 47-year-old male, previously healthy, who developed symptoms just over the last 2 weeks. Symptoms of drenching night sweats, abdominal pain, and severe fatigue over 2 weeks. Comes in to see you. Prior to that, he did palpate some cervical lymphadenopathy. And on exam, he doesn't look well. He does have palpable cervical and axillary adenopathy measuring 2 to 2.5 centimeters. The abdomen is full without a discrete mass. He's diffusely tender. Laboratory studies are significant for anemia. His creatinine is 1.2, which is elevated from his usual baseline. Uric acid 8.5, and his LDH is elevated. And PET scan shows fairly widespread lymphadenopathy, both above and below the diaphragm, with significant intra-abdominal bulk. So before we get to the question of what is treatment, I want to make an important point about the workup of these aggressive lymphomas. So this is the histology that the hematopathologist will see after a biopsy, showing diffuse growth, and they call it a possible starry sky pattern, which of course is the buzzword that we think of with Burkitt lymphoma. Based on histology alone, there's quite a differential diagnosis for this. This could be a case of diffuse large B-cell lymphoma. This could be Burkitt. This could be our double or triple hit lymphoma. It could be a high-grade B-cell lymphoma not otherwise specified. It could be blastoid mantle cell or lymphoblastic lymphoma, for that matter. So how do our pathologists tell the difference? You need FISH to diagnose these cases accurately. And so I hope to show a little bit of data to convince you that we need to do FISH on all cases of aggressive lymphoma, not just ones that look like this, even all cases of run-of-the-mill diffuse large B-cell lymphoma. We do find MYC rearrangements in about 10% of histologically diffuse large B-cell lymphoma, and then 30 to 60% of the high grades. The partner gene for the rearrangements are a little bit different in double hit and triple hit compared to Burkitt lymphoma. So this is something that the hematopathologists need to be aware of so that their probe strategy captures all of these rearrangements. So the question is, well, can't we just use immunohistochemistry as a surrogate? We can do immunohistochemistry for MYC, and that should be pretty predictive, right? Unfortunately, it's not. It does not have the sensitivity or the specificity to rule in or rule out these cases that have MYC by cytogenetics. And this shows the data. About half of DLBCLs are MYC positive by immunohistochemistry, but only 18% of those were MYC positive by FISH. And interestingly, 11% of MYC rearranged cases by FISH were negative by immunohistochemistry, and that's why we need to do FISH. Is immunohistochemistry still important? Yes, it is still important as part of the workup. As we know that patients who have double expression of MYC with other translocations do have a worse prognosis, but again is not predictive of a rearrangement. So the first take-home point I want to give you today is to fish all cases of large and high-grade B-cell lymphomas because the morphology and the phenotype are not necessarily predictive. And that may beg the question, well, what about cell of origin? We already talked about immunohistochemistry. That also does not help us very much for these cases. Although 100% of MYC and BCL2 DLBCLs are GCB, the ones that are MYC and BCL6, it's half and half GCB ABC phenotype. So that again does not discriminate to make the diagnosis. Here's some prognostic factors in these cases. One thing that has come out in recent years is that these cases can be de novo, of course, just like many aggressive B-cell lymphomas, but they can also come about as a transformation from a previous indolent lymphoma. And those transformed cases, you can see, have a worse prognosis than a de novo double or triple hit. Also, the cytology by histology is important. Those that look uglier, more high grade by cytology tend to have a worse prognosis than those that look more like a typical diffuse large B-cell lymphoma. They do have a tendency towards a worse prognosis, although not statistically significant, if it is a BCL2 partner as opposed to a BCL6. And then lastly, there was some data that stated the MYC partner was prognostic, but more recent data from our own institution has not shown this to be the case. Okay, so we've gone through that part. Now, how do we treat this patient who is presented with a high-grade B-cell lymphoma? So I'd love to hear from the audience. I know you all just had coffee not too long ago, so you're awake. So tell me, what regimen do you use at your institutions for induction therapy for patients with a double hit or triple hit? A Burkitt-like regimen, okay. R-EPOCH? In less fit patients? How about in a more fit patient? Codax MIVAC? Okay, anything else? Raise a hand. How many people send these patients to transplant if they get into a first remission? Okay, great. So let's go on with what the data shows. Again, we do not have a lot of data in these patients. Particularly, we have a dire lack of prospective data. So multiple institutions have published their case series of patients with double hit or triple hit and retrospectively looked at what type of induction therapy was associated with better outcomes. This is from Mayo Clinic in Rochester. We had 100 cases of double hit lymphoma that were confirmed and retrospectively reviewed. The numbers are small. We tend to give our Codax our IVAC in younger patients who are physically fit and do not tend to send those patients on to transplant in first remission. Those patients tended towards having a better survival, but because numbers are small, this was not statistically significant. But the point is that R-CHOP is always at the bottom of these curves in terms of outcomes. We have data from MD Anderson, who looked at their single institution experience. They had about 130 patients. And again, you can see that R-CHOP is towards the bottom of that curve, indicating that it is inferior treatment. What is at the top in blue is R-EPOCH. And what's interesting is if you look at the fine details, many of the patients who went into first remission in this analysis and other then did go on to receive transplant, making it difficult to find firm conclusions about the induction. However, those who get into a complete remission with induction, regardless if they go to transplant or not, have a better prognosis, which really indicates that the induction therapy is the most important part of therapy for these patients, not consolidation therapy. This is pooled data from multiple North American institutions, looking at, again, prognostic factors and can we determine which induction therapy is superior. You can see there was a mix of different therapies used, including RCHOP, other intensive therapies such as R-hyper-CVAD, dose-adjusted R-EPOCH, Codox-M-IVAC. They did an analysis of intensive therapy, lumping all of those together other than RCHOP. That was statistically significant for RCHOP being inferior when you look at event-free survival. Overall survival, it was not statistically significant, but when they adjusted for other prognostic factors, including the IPI factors, as well as other things that they found significant, such as CNS involvement at the time of diagnosis and leukocytosis, there was a statistical significant difference. So the second thing that is definitely clear in this disease is that RCHOP is inadequate therapy if you are treating patients for curative intent with double-hit lymphoma. We do have one prospective study. This is a multi-center, I believe 13 institutions participated. It was a single-arm phase 2 study in patients with MYC-rearranged lymphomas. So this included patients with single MYC rearrangement. 19 and 24 had double hit or triple hit. Patients all received dose-adjusted R-EPOCH as their therapy. What you can see is that the outcome curves look quite a bit different than what we showed initially. Patients had really an excellent 48-month overall survival at 76%. And interestingly, those who had double hit actually fared better than those with a single MYC rearrangement. I want to point out the toxicity of this regimen, however, in this particular disease. When you look at the toxicity of dose-adjusted R-EPOCH in the phase 3 randomized study in DLBCL, the treatment-related mortality was 2%. In this study, where these patients tend to be fairly sick, fairly bulky disease at the time of presentation, they may have tumor lysis syndrome, this regimen is associated with toxicity, and in this particular study of selected patients who are fit enough to go on to a clinical trial, the treatment-related mortality was still 6%, so it is not insignificant. Our Codox-M, for those who are not familiar, it is what I call the kitchen sink of chemotherapy. It is the most intensive regimen that I think we use in hematological malignancy therapy without giving stem cell rescue. And this is the R-IVAC portion. What's different about this regimen is that it incorporates, I think, more intensive CNS prophylaxis with high-dose methotrexate and cytarabine with the addition of intrathecal methotrexate and cytarabine. With dose-adjusted R-EPOCH, there is intrathecal chemotherapy, as you need to have prophylaxis in all of these patients due to the higher risk of CNS involvement. If patients have CNS involvement at the time of diagnosis, there is intensification built into this protocol, as well as the dose-adjusted R-EPOCH. I wanted to mention the supportive care for these patients based on that treatment-related mortality. 6% reported with dose-adjusted R-EPOCH, 7% reported with Codox-M-IVAC. Tumor lysis syndrome can be a significant issue at the time of diagnosis. Nausea is a significant issue. All patients require growth factor. Mucositis can be a significant issue, particularly with the Codox-M-IVAC. We use antimicrobial prophylaxis with acyclovir and Bactrim. And then, of course, many patients do require transfusions, particularly to keep them on track with the intrathecal chemotherapy that is built into the protocol. Just to mention that interim PET has been found to be associated with prognosis in this disease, just like most other aggressive lymphomas, so that should be built into part of the standard of care. So here's the big question. Is there a role for consolidation with stem cell transplant in first complete remission? It's an excellent question. The retrospective data is underpowered to answer this question, and there's also very much a mixed heterogeneous population that likely has some bias associated with who could go to transplant and who was felt to have more risky disease where transplant was chosen and not. So we really don't have answers. This is the Kaplan-Meier curve from the pooled data showing no improvement in survival if transplant was used in first remission versus observation. So the jury is out on this. The survival benefit is not proven. However, I think it is very reasonable to consider in your young, fit patients, particularly if they have some of those higher risk features, such as transformation from an indolent lymphoma or CNS disease at the time of diagnosis. What about those who have relapse disease? Unfortunately, this is a very challenging situation, and the prognosis is really quite dismal. One study reported overall survival of the 3-year overall survival from time of first progression of only 7%. In those who were able to get to transplant as salvage, following salvage chemotherapy, the overall survival was still only 15%. So this is really an unmet need in hematology. So back to the case at our institution, we do tend to treat with our Codox-M-IVAC in those who are young and healthy, using an absolute cutoff of age 60 for that regimen, and I would argue to be very careful between ages 50 and 60 as the toxicity is quite great. It requires inpatient therapy, it requires patients to kind of give up their lives during the time of therapy, just like acute leukemia treatment. He moved to Rochester, Minnesota for 6 months, had multiple hospitalizations for neutropenic fever and mucositis, but did achieve a complete remission. So take-home points. 1, I already gave you. FISH needs to be performed on all patients with an aggressive B-cell lymphoma, as the histology, cell of origin, and immunohistochemistry does not reliably diagnose these patients. R-CHOP is inadequate. Intensifying the therapy is absolutely necessary. Induction therapy is probably the most important part of curability for these patients. I think dose-adjusted R-EPOCH or Codox-M-IVAC or R-Hyper-CVAD are all reasonable options. Supportive care, though, is absolutely necessary with any one of these regimens, although dose-adjusted R-EPOCH is a little bit easier, of course, than Codox-M-IVAC. Include CNS prophylaxis with intrathecal chemotherapy for sure with dose-adjusted R-EPOCH. Other regimens have additional high-dose methotrexate or cytarabine built in. And consider autologous transplant in first remission in selected patients, recognizing that the survival benefit has not been proven. Thank you very much.
Thank you, Dr. Thompson, for a nice presentation. And we can have 5-minute questions, please. Yes, Doctor, please.
Thanks for the talk. So what to do with the patients with single hit rearrangement? So CMYC positive, but negative BCL2 and BCL6. Would that be an indication for upgrading the therapy more than R-CHOP?
That's a great question. So what do you do with the patient who has a single hit with just CMYC but not BCL2 or BCL6 rearrangement? So that would be somebody who presumably has the histology and the diagnosis of diffuse large B-cell lymphoma. So as long as the pathologist is telling me that it's diffuse large B-cell lymphoma, it doesn't meet other criteria that puts them into the high-grade B-cell lymphoma not otherwise specified, because they can make that diagnosis based on some of the cytological features, et cetera, the Ki-67. But as long as it's a diffuse large B-cell lymphoma with a single MYC rearrangement, I will treat them like a diffuse large B-cell lymphoma and not intensify their therapy, as I do not think there is enough evidence that to point us in that direction where the toxicity risk outweighs the benefit. I will say that many times, though, those patients do end up in this category of the high-grade B-cell lymphoma that aren't the double hit or triple hit by FISH, because they don't have those other rearrangements. And those patients I will treat just like a double or triple hit with intensified therapy. Thank you for the question.
Thank you, Doctor. Another question from, yes, Doctor.
Is the origin of the cells, whether they are GCB or non-GCB, does it has impact in the prognosis?
Yeah,
This is my first question.
Yeah, so does the cell of origin have impact on the prognosis? And the answer is no. Really, it's coming, the cell of origin does not. It is coming, and neither does the MYC rearrangement partner gene. It really comes from some of these other factors. The clinical factors of the IPI are significant, including, and then with a few other additional characteristics such as elevated white blood cell count, as those patients probably have a leukemic form of the disease. And then CNS involvement at the time of diagnosis also is a poor prognostic factor.
My second question is there anything going on about use of targeting BCL2 since it is used in CLL and is available?
Right. So the question is there any studies going on targeting BCL2? The answer is yes, there are some studies ongoing that are accruing patients looking at the addition of venetoclax to dose-adjusted R-EPOCH as the backbone therapy to determine if we can improve outcomes, which is, of course, targeting the BCL2. So more to come on that.
Thank you. The last question, we'll take it from Dr. Osman, please.
Thank you for the talk. So in patients who may have a CNS involvement as well, would that guide you to one therapy or another? Might you choose, say, Arcodox M-IVAC instead of R-EPOCH, depending on?
Right. So if somebody has CNS involvement at the time of diagnosis, does that help you make a decision of which induction therapy to use? I know that those patients have a worse prognosis, and so I want to be as aggressive as I can be. I would, if they are young and healthy enough, I definitely would do the Arcodox M-IVAC. I like the way that the intensification of the CNS involvement is written into that protocol. The dose-adjusted R-EPOCH does also have guidelines that they used in the phase 2 trial for those who had CNS involvement, but it doesn't include any of the systemic methotrexate or systemic Ara-C. The other thing that I would consider for a patient who has CNS involvement at the time of diagnosis, although the data is not there to support a survival benefit, but knowing the worst prognosis, I want to be aggressive, I would consider transplanting that patient, autologous stem cell transplant, in first remission.
Thank you, Dr.
Thank you.
Thompson, for a very nice and beneficial presentation.